Hello and welcome to this conversation. It's Howard Bachner, Conversations with Howard Bachner. And in some regards, this represents our continuing series of trying to bring people from around the world. Now, I've practiced these names all morning. I've looked them up. I'm not very good with pronunciation. I think people know that. But I am so pleased to be joined by Machado, who I'll introduce in a second, and Jorge Salluh, both from Brazil. I know both of them. They're very prominent, world-renowned intensivists. And we're going to be talking about Brazil this morning. Welcome, Slavio, and welcome, Jorge.
Hello, Howard. How are you?
Hello, thanks a lot, Howard.
I'm pleased to have you. So to frame the discussion, I thought I'd give people some data to begin with. Brazil has about 210 million people, and currently it's been reported that 1.23 million people have been infected, and there's been 55,000 deaths. This compares to the United States, that has about 330 million people, 2.47 million in the U.S. infected, and about 126,000 deaths. So I thought it would just be helpful. Brazil, in comparison to the U.S., is divided into 26 states, of which the two most prominent ones are Sao Paulo and Rio, whereas the U.S. obviously has 50 states. So why don't we start by both of you describing where you work and what it's been like for the two of you. Slavio, why don't we start with you?
Yeah. Well, I live in Sao Paulo. I am the chair of the intensive care department of the Federal University of Sao Paulo, which is one of the major public university hospitals in Sao Paulo. And we've been through this now for up to 3 months. And I would say that now we are finally maybe reaching a plateau, but it was quite hard in the beginning. São Paulo, as many major cities in Brazil, we had some time to prepare. And São Paulo also, it's quite well served from ICU beds. We have 5,000 ICU beds in the city. So it's quite reasonable. But this before the pandemic, so this ICU capacity was also spread both in private and public hospitals. As in any city in Brazil, there is inequality in the distribution between private and public, not only ICUs, but hospital beds. So certainly in the public system, things were much worse. There were some times or some weeks in which the public ICU capacity, the occupation was up to 95%. It was also different. It was this pandemic. It's amazing how it was going through all the like in the beginning, on the first wave, we had the private system and the private hospitals more occupied because it was from people that were traveling abroad, and then. After that, we have this problem with the public system, and now the private system are much less occupied, and we are maybe reaching a plateau.
Slavia, did you have to expand the number of ICU beds like they had to in Italy and New York, London, Paris? I mean, Sao Paulo is a major world city, so did you have to expand the number of ICU beds?
Yes, certainly. In our hospital, we almost tripled the number of ICU beds. And in the major hospital of Sao Paulo, which is also the major hospital of Latin America, which is the University of Sao Paulo Hospital das Clínicas, the whole hospital became a COVID hospital.
Oh, it did.
So they have expanded for 300 ICU beds. They have put beds in the operating theater. They turn wards into ICUs, as we did. So we transformed 3 wards in ICUs in our hospital. And this was a movement that was made by major public hospitals in Brazil.
Now, Jorge, you're from Rio, so why don't you describe what it's been like there and what's happened there?
Yeah, so in Rio, the scenario was a little bit like what Flavia mentioned. So I think that somehow we were lucky that there was some delay between the wave of the pandemic in Europe and what happened in Brazil, so that we had maybe 4 to 6 weeks of preparation. And within this time frame, we, in the state of Rio and actually all over Brazil, but for sure in Rio, we managed to expand our capacity to have these COVID patients coming. The problems, Howard, were that although we created a large number of new ICU beds, both in the public and in the private sector, and also that we got all the elective procedures canceled, et cetera, making even more room for these patients coming in. I think that the problem was mostly that maybe we were at baseline not well prepared to treat these patients. I was just chatting with Flavia just before this, we initiated here, and one of the challenges that we found was that we have already, I could say, a low staffing pattern all over the ICUs, meaning both physician to bed ratios and nurse to bed ratios. And so what happened was, when we look at baseline utilization of resources in critical care, in the private sector, usually 15 to 20% of the patients are ventilated. And even in the public sector, maybe the average would be 45 to 50% of the patients ventilated. And then we experienced the surge of patients. And even though we might have had enough ICU beds, we didn't have enough staff to care for these patients properly. So to be able to ensure proper standards of care for these patients was maybe the biggest challenge of all for the ICUs that where enough beds and ventilators were available. Of course, in Rio, there was also some problem and some delays in the availability of beds in the public sector, making it sometimes complicated to get an access to a public ICU bed. Still, we had some time to prepare. But I think that the staffing pattern was actually the biggest problem.
Now, both of you are clinicians. You take care of patients, and you've read the reports in all of the major journals. You've talked to your colleagues. The intensive care unit community is very small. I've been impressed with it for many years. Flavia, has the clinical entity been the same for you as has been observed in London and Paris, New York, and Italy? Has it been similar? 20, 30% of the people needing to be ventilated, mortality rates 20 or 30%, a real struggle with maintaining oxygen saturation. Has the clinical entity been the same?
Yeah, I believe so, that are pretty the same. I would say that what maybe it's different is because, as you might know, we have different profiles in low and middle income countries and high income countries regarding, for instance, healthcare-related infection and multi-drug resistance. So this was already different between high income and low and middle income. And I think that this posed to us a different challenge, because I would say that the COVID per se, it's pretty much the same of all the reports we have seen. But then this long duration of ICU stay imposed to us a new challenge, which is to get better in prevention of healthcare-associated infections. And we already had a lot of problems with multi-drug resistance, KPC, VRE, and this is still there. But before, we had, as Jorge said, around 45 to 50% of the patients were really sick and on mechanical ventilation, and now sometimes it was 95%, all the patients. So the criteria for admission in the ICU in public and private system are different. Right. So these patients are much more sick in the public ICUs, so they complicate much more. So I would say that maybe this is different. We have not, in all our experience, we have not lost a single patient because of refractory hypoxemia. We only put one patient in ECMO. We are losing patients for refractory septic shock, mostly.
Treatment, a lot of controversy remdesivir, for us convalescent titers, steroids now, all of the drugs that block the inflammatory cascade, the concerns about thrombosis and the use of heparin. Probably 100 articles have crossed my desk about experimental therapies. It's clear that remdesivir has some success. It's not overwhelming. People want to see the details of the recovery trial. We've published extensively on convalescent titer. What's been the approach in Brazil?
Well, I would say it's a little bit, it varied. As you might have heard, we had some problems with our president, which was a hydroxychloroquine supporter. And many people in the beginning were using this even in patients outside the hospitals without any evidence. Then I think after the new studies, this is changing a little bit. So, for instance, I would say that now many people just stopped using it. We don't have a remdesivir.
Okay.
It's not available in Brazil. And even if it was available, I would say it would going to be very expensive for us. So, and another option that you mentioned, with dexamethasone, I would say that it was also the use of dexamethasone varies among the hospitals. But after recovery, I would say that most people are using it. As you might know, there is a lot of studies also running in Brazil.
Yes.
We just finished 2 of them with hydroxychloroquine. It's the coalition trials. There are actually 8 studies running at this moment. We just finished 2. We are finishing now, because of the recovery, the dexamethasone study. I would say that we need these results to get a final answer. And we need the publication of recovery to have a final answer about hydroxychloroquine.
Jorge, what's your sense of what you've been seeing in Sao Paulo, in Rio, in your ICU, and talking to your colleagues in Rio?
I think that it has changed a lot over time. I think that at least it's my impression that at the beginning, with little evidence, but I would say in a very reactive way, people were really scared of what was going on with the surge of very sick patients and very little specific therapies that they could offer. So it's my impression that in general, intensivists used a lot of these adjunctive therapies, or such as hydroxychloroquine, steroids, even other types of therapies in the beginning. I think that as people got more of the experience and as evidence became available, it represented a real shift. So it's my impression through exchanges with colleagues, etc., that the use of hydroxychloroquine, for instance, has diminished in critically ill patients. The use of steroids it's my impression, it remained the same. There's a very strong steroid culture in sepsis and ARDS already. And for these patients, because they are refractory sometimes, or at least they take a long time to improve the oxygenation parameters, I think that lots of clinicians use steroids in these patients even before evidence from the recovery trial. I think that now it's going to increase. Still, I think that there's also an important link to what Flavia mentioned before. If we are maybe working with heterogeneous standards of care, especially in the infection control practices and the prevention practices, and we are in a multi-drug resistant bacteria environment, I would worry a little bit with very liberal use of steroids, even though this safety concerns are not in the trial.
Jorge, one of the other issues that's emerged has been the approach to mechanical ventilation, or to prevent the use of mechanical ventilation. And there's been a great deal written about use of proning. And I'm curious how the two of you have utilized it in your ICUs, particularly in places. I mean, I interviewed Mauricio and Derek last week. I think, Derek thought that the use of proning had really increased in part because of the need to try to prevent more ICU stays and mechanical ventilation, and that it had been successful with some patients but not others. And I'm just curious what your impression has been about the use of proning, either in the ICU or outside the ICU. Jorge, why don't you take that one?
Yeah, so very quickly, I think it was a trial and error process. In most, I think that people felt very comfortable with using prone position in the non-intubated patients, like the self-proning maneuvers. And I really believe that if the patient was monitored, that was really fine, at least to try it. And I think that most clinicians felt that this could be some way to avoid intubation on top of other strategies such as high flow oxygen therapies or non-invasive ventilators. However, for the ICU patients, what I saw was a scenario that was very heterogeneous as well. So some people that maybe had more experience or more staffing, they would work and be more proactive with proning the ventilated patients in the ICU, and maybe others, due to restrictions in staffing or the safety concerns over monitoring the patients, etc., would leave it to a later stage. That's at least my impression.
And Flavia, what's been your impression of proning?
I think it's more or less similar to Jorge. We were always a very proning ICU, so we prone our patients regularly. So I believe that Jorge is correct. If you are not you don't have this culture of proning patients, you're going to be challenged to have many patients proned in the ICU at the same time. And even more to prone awake patients, not on mechanical ventilation. Because we are doing this a lot. We try in almost all patients to have them in prone position when they are not ventilated. But it's not totally safe. You have to be very aware about what you are doing. They have to be monitored. You have precautions, and you have to have a staff that is able to supine them very quickly if they need it. So in a cultural environment that it's proning patients already, I would say that it's quite safe. In people that are not used to prone, I would say it's better to start with the ventilated patients.
It's interesting, Flavia, this is both of you have talked about kind of culture, local culture, and I think that's true in medicine everywhere, particularly when there's uncertainty about the data, steroids being a good example. There's a couple questions have come in, and I want to start, we talked about this before. The U.S. has struggled. Our executive leadership has not always been very supportive of the public health messages. Dr. Fauci, Tony Fauci, has found a way in which he appears to be able to disagree with our president and to try to deliver a consistent public health message. It has been an enormous struggle in the U.S. Somehow we've figured out a way to make masking a major political issue. I read the reports from Brazil. You've had your own struggles, so I'm hoping that both of you could just comment about where you think the struggles have been and where have been the successes.
Well, yeah, I think that we have our own Trump. That's the Brazilian Trump, our president, and his position was totally wrong on this. I would say that he turned this into a political issue between right and left, between their parties, their staff, and the last president and the Labour's party. So if you are from the right side, you are pro-hydroxychloroquine. And if you are from the left wing, you are against it. So it was not a scientific issue. It was a political issue. They needed to support. And also our president was, I think, like yours, going out on the street in the middle of the population without mask. Yeah. They were kissing children, hanging people without mask. So I personally think that he is personally responsible for a lot of what's happening in Brazil. And our Minister of Health, they were quite appropriate in the beginning. And as you know, he changed two times our Minister of Health, and we end up with a military in the ministry, which is doing a good job as well as the previous ones. So I would say that the Minister of Health had a huge and great and quite important role on supporting everything that is scientific and approved by the health authorities all around the world.
Jorge, would you like to make any additional comments?
Yeah, I think that I fully agree with what Flavia mentioned. I would even go a little bit further on the hydroxychloroquine case. To me, it was not even that the right-wing supporters were pro and the left-wing supporters were against. It was that if you were against, you are left-wing, and if you are pro, you are right-wing, and you're labeled on your scientific opinion as a political matter. So that's really crazy. I think that the biggest challenges, apart from the hydroxychloroquine, because I think that this was a huge distraction for us. I mean, there was no evidence at all at baseline, and we still don't. And we kept, burning our energy and efforts in sterile discussion that would be ended if we followed the good clinical practice and evidence-based principles from the beginning. So I think that worse than discussing the drug was the waste of time and the waste of the opportunities to support isolation, the use of masks, and above all, the central coordination of resources.
Right.
Because at the beginning, as I mentioned before, we had time. We had 4 to 6 weeks to get prepared. It's not a lot, but it's better than some countries that saw it coming very quickly. So we had 4 to 6 weeks, and still some cities struggled because the way that the health system is organized, although it's managed locally at the city level or state level, it's financed by the central government. So the lack of coordination of resources and of timely intervention that was caused by political issues, I think that's responsible for a lot of the problems that we have been through and what we're going to experience the next week.
In the U.S., our failure around testing, our failure to provide personal protective equipment, PPE, has reached almost legendary status within 3 months. It's extraordinary. It's gotten better. And then, of course, the effect on healthcare workers, physicians, nurses, everyone who supports physicians and nurses, the number of physicians and nurses and others that have been infected. Flavia, has that been an issue? I'm assuming PCR, testing, PPE, effect on healthcare workers. What's it been like for you and your staff?
Personally, in our hospital, we have our supplies okay for the last 3 months. Okay. But supply was an issue, certainly. And I would say that the supply issue, they had 2 waves. The first wave was PPI. I mean, some hospitals were without masks, without gloves, and then the industry, they react to this, and the supply was regular, it was okay again. But then the second wave was the lack of medications. So now we are missing propofol, midazolam, potassium bicarbonate, neuromuscular blockage. So there is a second wave in which the industry, the Brazilian industry, is not answering quite well as the industry of protective equipment answered. And we can discuss this further. But going back to the healthcare workers, I would say the issue was, as many people were not protected, we already had, not in our hospital, it is okay, but we know that we are missing people to work in the ICUs. And then there was all this wave about opening ICUs, ventilators, producing new ventilators and cheap ones, and people were opening ICUs with all equipment and without people to work. Because as Jorge mentioned, there is a lack of qualified healthcare professions to this increase in the ICU capacity. So people think that an ICU is a ventilator, and it isn't. The ICU is a team taking care of all the equipment.
I mean, when New York said they were going to double the number of ICU beds, I said, that's a great idea, but can you tell me who's going to work in those ICU beds?
Exactly.
It's really a complicated issue. And you can't just take a physician who's a neurologist and put him or her in the ICU. And the same with nurses and support staff. It's really coordinated, highly technical, complicated care. So I've always been a bit concerned when they said, well, we'll just double the number of ICUs.
Yeah, but some people helped us. For instance, as Jorge mentioned, there was a reduction in the elective surgeries.
Right.
So the anesthesiologists are quite well to work in the ICU.
Right.
So if you have an intensivist running and coordinating the unit, those doctors are completely able to work in the shifts. So, and we also recruit residents for other specialties to help. So it was manageable, but it is still very hard.
Right. No, it took a lot of movement of people. So in the U.S., I think emergency room physicians, hospitalists, anesthesiologists can really help in the ICU, and then you can backfill those other positions as long as you have an intensivist who's overseeing the entire entire program. Georgie, PPE, PCR testing, your staff, what's it been like? What's it been like in Rio?
So I share the vision that Flavia has just provided. I would add that maybe we managed quite well in terms of physicians, but we didn't manage so well in terms of nursing staff. So that's something that we saw. And, even though we can take anesthesiologists in and they can fill in for critical care physicians, it's harder to get the nurses that are working on outpatients or oncology or other wards, and then getting them to be supported in the treatment of the sickest patients they've ever seen in their life. So that's something that is really challenging, I think, into coordinating care. In terms of testing, I think that Brazil is very big, and it was very heterogeneous in terms of policies, availability of PPEs, availability of testing, even within hospitals in the same city or the same. And it's not just a matter of public-private. It's a matter of how quick the administrators were to respond. So we saw in Rio a wave of healthcare professionals getting sick. Some of the first cases of death in Rio, one was a physician, a nephrologist, several healthcare professionals got sick, let's say in the very first few weeks. And that was very challenging too, because on top of all the challenges and on top of course, the health burden for these professionals and their families, there was also the fact that we were already running short on staff. And they would need to stay 14 days plus to come back to work if they were fully recovered. So I think that it was very heterogeneous. I think that in general, I agree with Flavia. I think that both industry administrators, a little bit late, but still timely responded to the PPE issue. But this was a big toll on our staffing, I think.
Some clinical questions have come up, and I know both of you are just extraordinary intensivists. There's been a lot written about cytokine storm and trying to intervene. There's been a lot written about vascular abnormalities and the use of heparin. Have either of you explored this in an experimental way, or if really, Georgie, it was interesting. You said good clinical practice. Like, what do we know we should do for really sick patients? But so many of these different ideas have crossed my desk. I'm wondering if either of you have seen some attempts around cytokine storm or thrombosis to intervene. Flavia?
You want to start, Flavia?
Well, I believe that these drugs, except for some situations, should be used only on RCTs, only in randomized clinical trials.
Right.
The coalition, which is a coalition between among excellent hospitals in Brazil and two networks, including BRICNet, are doing a trial with Tocilizumab, and I believe that we need to wait for the results. And as I believe George mentioned, we should have a precaution in our settings, mainly in the public system, because we do have very sick patients and we do have problems with healthcare-associated infections. So the reality and trials conducted in high-income countries, for instance, with Tocilizumab, will not reflect the reality in low and middle-income countries. Not inside Brazil, it's the same. So maybe you can demonstrate that it's the efficacy and safety in private, nice hospitals, and this will not translate in real results in public and regular hospitals. And then maybe you can have a final result saying, oh, this works. And when you put in the real world, it might be dangerous. So I believe that we need evidence. We need evidence from our settings, not from high-income countries or from very nice hospitals for all of this. And it's the same with heparin. We have been using in some patients. They have D-dimer, they have very high levels of D-dimers. They have shunt. They seem to be different from the others. So then we discuss and we decide, okay, in this patient, we will use full dose heparin, but usually not. We are just using prophylaxis.
Your comment, Jorge, I'll have you mention. That's exactly what Mauricio said to me last week. It's the patient in front of him that he's making a decision about. He said, look, we know what good clinical practice is, but because there's a lack of evidence, it's the patient in front of me, as he was talking, that he was basing the decisions on. It was interesting. And he said he does think there's different phenotypes. And so he was trying to respond to that. Georgie, your sense of kind of these more experimental treatments, Toci, heparin, for the phenotypes that have been described, was there much use in Rio?
Yeah, maybe too much use in Rio. I think that, I think that what we're seeing now, Howard, is the 30 years of sepsis ARDS in 3 months. So we're going back again into all the cytokine storm, all the endothelial activation, all these pathophysiologic, very sound concepts that we saw at the bedside for patients with sepsis ARDS in the last 30 years, and that were actually not confirmed to be targets, at least for the interventions that were tested within this period of time. So, of course, we are tempted to do things and to intervene. So if the patient has a thrombosis, of course, he's going to get anticoagulants. I think that's fine. But if he has, let's say, a more pro-thrombotic profile, just because he has changes in coagulation patterns, D-dimer levels, whatever, well, that happens also in community-acquired pneumonia. That happens also in the community-acquired sepsis that we have seen for a long time. And all these interventions to modulate the inflammatory response or the coagulation have never worked. So it's my impression that at this point, although I believe that there could be a role for it, there is not enough evidence. And if we look back, what the history tells us is that it's not probably going to work for all patients.
Yeah,
to say the least.
We've received so many observational studies, very small case series, and we've really been reluctant to publish them. We know papers in JAMA get a great deal of attention, and so we've really been hesitant to fuel a kind of experimental treatment that we know in the past hasn't worked, and the data are just so limited in this pandemic. Many questions, but I have two more, and then I feel like I have to allow the two of you to get back to your regular work. Our risk groups have been pretty clear from the beginning, and the epidemiology has been really clear from our very first report in China to the reports that we've published from Italy and from the UK, from Spain. 60, 65, 70 years old. In the US, people coming from nursing homes, skilled nursing homes. And then obviously people who are frail, people have talked about the older patient with hypertension or the patient with obesity, that their mortality rates when they end up in the ICU are 15, 20, 25, or 30%. Jorge, has that risk group been the same for you around mortality?
So, yes. So we have gathered data from significant percentage of Brazilian ICUs. So we have a registry where it covers roughly 1/3 of the Brazilian ICU beds in the different regions. It's not necessarily epidemiologically representative for each region and has a little bit of imbalance in terms of private-public, but still, we managed to look at data recently until the end of May for almost 15,000 patients admitted to intensive care. So we could see some interesting information. So the first thing that we saw was that almost 60% of the patients had less than 65 years old. And when we looked into this data a little bit deeper, we saw that 1/3 of the patients were less than 50, actually. So I think that although the elderly patients, they come to our ICUs in large numbers, and there's also data from our group showing that age is actually, again, confirming the other epidemiologist data, risk factor for mortality. There are also a large number of younger patients getting to the ICUs. Of course, their outcomes are better. Another topic that you mentioned was on frailty. So we have measured with modified frailty index the frailty of these patients coming to intensive care, looking at comorbidities and activities of daily living of these patients before getting sick from COVID. And what we saw was that frailty was also definitely, regardless of age, an independent risk factor for mortality of the patients. But of course, if you put it together, elderly patients, especially those older than 70, 80, plus frailty, that would lead to a very, very high mortality rate. Another thing that I must mention is that we always, in terms of epidemiology and results, we always discuss differences in Brazil due to access of care and standards of care in mortality between the public and private sector. And that's true that when we looked at data from these ICUs, the mortality in the public sector is almost twice as the mortality in the private sector. But when we look strictly at the ventilated patients, it seems that these differences disappear. So what it means to me is that it's actually bed availability and access to patients with a lower severity. But when it comes to the sickest patients, which are the ventilated patients, our hospital mortality rates or the 30-day mortality are something around 65%, which is very high at any standards.
Now, Flavia, you've mentioned public-private a few times, and obviously in the U.S., we've really struggled with that in this pandemic. Not necessarily the public-private hospital, but what we've really struggled with is the unmasking, once again, of healthcare disparities between people of color and people who are white, that the mortality rates are substantially higher in the U.S. among people of color. And you've commented on the public-private hospital difference. What's been your impression of, the high risk groups in Brazil?
Well, I think that it's pretty what we already discussed is the age people, but we also have more young people than U.S. certainly. I would say that it's because of the comorbidities and the baseline healthcare condition of these people. But there was an interesting study on Sao Paulo city, and some of the areas that are heavily beaten by the pandemic. These are the poorest areas in Sao Paulo. So one of the neighborhoods that are pretty much beaten, it's a Brasilândia. And in Brasilândia, 26% of the inhabitants lives in slums. And the access to health, it's pretty worse than in the richest area. So I would say the inequality within a country makes a huge hole. However, if you think this in a more global sense, it is interesting to notice that when we talk about sepsis, and we talk a lot about sepsis, and we say that 85% of the sepsis cases are in low and middle income countries. This virus is a little bit more, the equity in this virus, it's interesting. Because when you look at the 10 top countries in the world, in number of cases, 4 of them are high income countries. So it's US, it's UK, it's Italy, it's Spain. So 85% of the deaths or the case are not in low and middle income countries. So why this? And I think that what determines incidence and mortality in sepsis is the host, the pathogen, and mostly the healthcare system. But with COVID, maybe the host, the age, the comorbidities, and the pathogen by itself is playing a major role. That's why the high-income countries are so heavily beaten, differently from any bacterial sepsis that we have heard before, which is in Africa. So talking about inequalities, difference in healthcare systems, private and public, it's quite difficult with this pandemic.
I want to conclude with a question to both of you. You know, over the last couple of weeks, I think the U.S. is moving away from this concept of a wave where there's then a long quiet period and a second wave. I interviewed a prominent public health person earlier this week who talked about it being more drip, drip, drip. It's just going to be, there's always going to be disease. There's been an outbreak in Germany. There's a new outbreak in Beijing. In the United States, we're struggling both in states that opened up early and in states that didn't open up early. Flavio, I'll start with you. A sense of what the next 3, 4, 5, 6 months look like in Brazil.
Well, I would say it depends on the city, on the state. Things are pretty better in the north and in the northeast. They're already going back to the new normal, but things are getting worse in the south because we have winter. We are in the winter,
right.
And the south of Brazil is quite cold. So it will depend. But taking Sao Paulo as an example, because the epidemic started here, I would say that in the next 2 or 3 months, we will reduce again the number of ICU beds dedicated to COVID. We will close the campaign hospitals that we have now in the city. And we need to be prepared for the new reality, which is already happening. For instance, in our hospital, if you have COVID, you will get an ICU bed. But if we are a non-COVID patient, it will be much worse to get an ICU bed. So in hospitals where you have the 2 tracks, COVID track and non-COVID track, now things are getting worse for the non-COVID because trauma is rising, the elective surgeries are happening again, so we are starting to move again from the non-COVID. And we will need to be prepared for this, not for 2 or 3 or 4 months, but until a vaccine is available, and broadly available for us as well. So I would say that in the next 1 or 2 years, we will need to learn how to have a COVID and a non-COVID. And we need to have new rules about testing patients for admission, for elective surgery. So the challenges of having the 2 tracks, we're going to be present for a long time.
Yeah, we'll put the equity issue around vaccines aside. We've had papers on it. We have more papers coming. I fear that the rich countries will buy it all up if they can, and it will not be equally distributed. I know that a number of groups are trying to sort through this, but it's a complicated issue. Jorge,
can I make a comment?
Sure.
Small comment on this?
Yeah, go ahead, Flavia.
Our federal university is running a vaccine trial together with Oxford. We are going to vaccinate 2,000 people together in Sao Paulo in our hospital. So this is interesting because we are having a vaccine trial in Brazil. Well, so what's going to happen
after it's approved? Right. You should make sure you make a deal that if we participate, we get some of the vaccine.
Exactly.
I mean, last week I spoke to Paul Offit and Tony Fauci, both vaccine experts. And one of the things they said is one of the keys about the 3 or 4 trials that are going to quickly roll out is that, one, you have to include patients where there's disease. If you include patients where there's no disease, you'll have no efficacy data. And then who's included, age and frailty and issues like that. Jorge, the future in Brazil, this is the last question, and then we'll stop. The future in Brazil, what's your sense of it?
So I think that adding to what Flavia already mentioned, I think that we are pulling very quickly maybe too quickly, the isolation measures, because we do not have consistent drops in the new case rates or in mortality or even in occupation rates in the ICUs at this point. But there's a lot of pressure on the economy. Brazil's been suffering from economic crisis for many years right now, so people are struggling. And I think that this will be a very complicated combination to be more flexible in terms of going back to normal when we are still having more than 1,000 deaths per day at this point. Also, I believe that this will actually provide us a scenario which is different from what we're seeing in the European countries. Not only because the country is big and there's all this heterogeneity, but because I think that we're actually not going to leave the first wave so soon. So I think that, as you mentioned, cases will still be dropping continuously throughout time. So I think that this will be a very challenging year for intensive care. First of all, because we'll still have an important number of cases coming in, and second, because we are not very well prepared, and I don't mean just Brazil, but very well prepared to run ICUs where these patients will coexist and give the adequate priority of care that they deserve, either to treat their chronic conditions such as surgery for cancer or heart disease or neurosurgery, and even though elective, they have to be done at some moment for these patients, and also to treat the continuous flow of cases that we are still experiencing. So I think that we are reaching a plateau and people are like being flexible about it and going back to the streets, and there are mega traffic jams already in Rio and Sao Paulo. So I don't see it in a very optimistic way.
The tension you mentioned about trying to open up so there's economic recovery versus balancing it with continued public health needs is true, I think, in every country in the world. This is Howard Bachner, editor-in-chief of JAMA. And for the native Portuguese speakers, I do apologize about my pronunciation. I struggle in English, so you can imagine how difficult it was. What a pleasure to be joined by Flavia Machado and Jorge Salluh from Brazil. The goal of these live streams are to hear from people from around the world. So Flavio and Jorge, thank you so much for joining me, and please stay healthy, and thank you for everything you do on behalf of patients.
Thank you.
Bye-bye, Flavio.
Thanks a lot, Howard.
Bye-bye.
Bye-bye. Stay healthy,
Bye-bye.
both of you.
Thank you. Thank you.